Okay, Assalamualaikum and good morning, everyone. My name is Nasrina and I'm emergency physician from Hospital Putrajaya. So thank you very much for joining us for our Saturday class. We have 2 sessions today. So the first session, we have a guest speaker. I'm very honored to have him. He's a colleague of mine when I was a younger medical officer, I guess. All right. He has been a great colleague. His name is Dr. Khoo Ching Soong. He's a senior lecturer and consultant neurologist in University Kebangsaan Malaysia Medical Center. He obtained his degree in Crimea State Medical University, Russia. Then he obtained his MRCP in the year of 2013. And subsequently, he pursued his interest in neurology and was awarded with the Certificate of Completion of Subspecialty in Neurology Training in the year of 2020. Well, he has a lot of fellowships, memberships. He has special interest in epilepsy. And I think he's a great person. I would summarize that. He has very good academic CV as well. And without further ado, I would like to invite Dr. Khoo to deliver his lecture on the topic of dementia beyond memory loss. So Khoo, the floor is all yours. Thank you.
A very good morning to all of you. Thank you, Nas, for inviting me to deliver a talk on this very lovely Saturday morning. So before I begin, can I confirm that you can hear me talking?
Yes, we can.
Perfect. So once again, thank you. I think on this Saturday lovely morning, everyone is very fresh and excited about learning something. I hope that this topic, dementia beyond memory loss, will enlighten and benefit you a bit. So again, my name is Dr. Khoo Ching Soong. I'm a consultant neurologist and senior lecturer from the UKM Medical Center, Malaysia. Okay, so I think before we begin to talk in depth, that's very important to define what dementia is. So nowadays, dementia is replaced by a newer term called major neurocognitive disorder, which is characterized by a decline in cognition, which involves either one or more domains, including learning and memory, language, executive function, complex attention, perceptual motor, and social cognition. And when you see a patient with dementia or suspected dementia, the symptoms must be severe enough to interfere or affect their daily activities, and they also report to lose independence. Consciousness is, however, not affected, and it shouldn't be a part of the normal aging process. Before developing dementia, there is an intermediate clinical stage, which is now called MCI, mild cognitive impairment, which is also a precursor to dementia. This graph represents the classic clinical course of Alzheimer's disease, AD, whereby the x-axis represents the years of development and the y-axis represents the cognitive function. As you can see from this dashed line and representing the continuum of AD, okay, from the very beginning, there's a preclinical state whereby both the family members and the clinicians fail most of the times to detect because they are simply, asymptomatic. As years progress, the patients will develop into MCI and subsequently into dementia, versus the solid line representing the normal aging process. So why are we talking about or concerned about dementia? As we know, kudos to our healthcare system. We have more and more elderly people around us, and they live longer. We probably know by now that in the globe, we have around 50 million people who are living with dementia. And close to 2/3 of them are actually from the low or middle income countries, including Malaysia. And nearly 10 million new cases are reported every year for dementia. According to the statistics by our Malaysian researchers, we are expected to have nearly 600,000 people with dementia by 2050. And the overall pool prevalence of probable dementia stands at 8.5%. So looking at this mind-boggling number, I think this is and would be a huge healthcare burden to all of the healthcare professionals, regardless of your fraternities. Dementia is actually an umbrella term, which is well represented in this graph, under which there are many forms and types of dementia. Alzheimer's disease, AD, being the most common form among all, which accounts up to 80% of all dementia cases, which is then followed by vascular dementia, mixed type of dementia, frontotemporal lobe dementia, dementia with Lewy bodies, and Parkinson's disease dementia, and others. Similar to any non-communicable disorders or diseases, dementia is also caused by a combination of both genetic and environmental factors. So these factors can be classified into non-modifiable and modifiable risk factors. So let us start with this non-modifiable factors. Age, advancing age more than 65 years old, females at risk of developing dementia, in particular in AD, and of course, some genetic factors. So take late onset AD and sporadic early onset AD as an example. The presence of the epsilon-4 variant of the apolipoprotein E allele is responsible for this disease. However, as clinicians, we must understand that this variant may not be necessarily sufficient to cause the disease. So when interpreting the diseases, we need to be very careful. Another typical genetically related dementia would be Huntington disease, HD, which is a well-known autosomal dominant and trinucleotide repeat disorder. So we know that modified factors are something that we can modify. So I'd like to spend more time on this so that we can try to improve and try to prevent people from getting suffering from dementia. So what are they? So first, cardiovascular risk factors. That would include what we know already, which would include your hypertension, diabetes mellitus, dyslipidemia, obesity, and smoking. And they are proven independent risk factors for the development of vascular dementia. So when we see patients with any of these risk factors at our clinic or emergency department or in the wards, apart from our usual job of telling them why we need to control, optimize risk factors to prevent from developing life-threatening conditions such as acute coronary syndrome, major stroke, we need to also emphasize by doing that is also crucially important to reduce the risks of developing dementia. And according to a systemic review, it shows that if you treat the elderly patients with high blood pressure with any angiotensin II receptor blockers like losartan, temsirtan, it seems that the cognitive function includes. And thirdly, high total cholesterol is also a risk factor for developing late life dementia. If you have patients with late life depression, it also confers a twofold increased risk of dementia as well as AD. So now let us look at the lifestyle. If you have a patient who smokes excessively, consume alcohol excessively, they are also at risk of developing cognitive dysfunction and dementia. One important factor or point that we need to highlight to the patient is that if you lead a sedentary lifestyle, you also stand at risk of developing dementia. So according to a meta-analysis, which shows that physical inactivity measured 10 years before the diagnosis of dementia was actually associated with an increased risk of all-cause dementia with a hazard ratio of 1.4 and AD with a hazard ratio of 1.36. These are all actually very alarming risks. So in 2020, the Lancet Commission also discovered a few risk factors that could be very strongly associated with dementia, which include a lower early life education level, midlife hearing impairment, and also midlife traumatic brain injury, regardless of the cause, which have a relatively risk ratio from 1.6 to 1.8. So ladies and gentlemen, I think when it comes to dementia, one of the very important things, or one of the very important modifiable factors that is the talk of the town and people are talking about it is the sleep dysfunction. In 2021, Xavier and her colleagues published a very important topic on this association of sleep duration in middle and old age with incidence of dementia in the Nature Communications, the discoveries of which did shatter the world. And from their paper, they found that people who sleep 6 hours or less per night in their 50s and 60s are actually at risk of developing dementia later in their life. And the risk is increased at 30%, independently of the socio-demographic, behavioral, cardiometabolic, and mental health factors. So what they concluded was that if you don't sleep enough, especially in your 50s and 60s, the risk of developing dementia is elevated. And thus, please sleep early and more. That's the take-home message. So why would sleep dysfunction have a bearing on dementia? So that's a term called impaired glymphatic function. So this is a relatively newer term, which again is widely discussed among the geriatricians, the sleep specialists, and neurologists. So what is the glymphatic system? If I were to put in a more understandable term, glymphatic system in the brain is like a detox system. It is considered as a pseudo-lymphatic network that is distributed throughout our brain, which is responsible for replenishing, cleansing the brain, as well as consolidating your memory. So this glymphatic system is important to detoxify the toxins and other harmful substances from the brain. And this system typically works actively and more efficaciously during our deep sleep, for example, our non-REM sleep, stage 3. So if we do not sleep well, or we have interrupted, fragmented sleeps, and we do not get into the non-REM sleep, this lymphatic system fails to work. Thereby, neuroinflammation, arteriosclerosis, alpha-synucleinopathies, typically occurring in Parkinson's disease dementia and DLB, which subsequently leads to impaired amyloid beta clearance, leading to a buildup of these toxin substances. And that's how we get dementia. So this is a very nice a graph to show how this lymphatic system works. So it's mainly responsible for cleansing and detoxifying the brain so that we feel fresh after a good sleep. So putting all together, physical inactivity, sleep deprivation, and possibly traumatic brain injury from our patients, actually doctors are at risk of dementia. So now we are going to talk about the clinical presentation of somebody with suspected dementia. Typically, the patient does not come to the clinic himself or herself with complaints of memory loss. They are usually accompanied by their next of kin, family members, spouses to our clinic to tell us about the memory loss. And informed reported memory loss is much more a predictor, of the current, presence, and future development of dementia. So bear in mind that forgetfulness is part of it, could be a symptom of dementia. However, there's more to it. So by the time when the patient tells you or is brought to the clinic by having complaints such as stopping driving or managing his or her finances, the subtle or silent symptoms may have gone for years. So forgetfulness or becoming easily forgetful is usually invariably a chief complaint. However, as clinicians, we don't just talk about how forgetful the patient is. We try to get more instances from the patient or his or her family member. So what are the examples that the patient can't do, or you feel that this patient has some difficulty doing? So these are all the things that I can list down for you to ask if you have time, at your very busy clinic hours. Try to get more events so that you can conclude if the patient has dementia or not. First of all, very important thing, we try to ask if the patient is able to retain any new information. Usually, dementia patients can remember things that happened years or decades ago. However, if you ask about, have you taken your breakfast? What did you have for your dinner last night? They might have to struggle to remember all those events. The next thing is how well the patient can handle the complex tasks. For example, managing finances, balancing a checkbook, withdrawing the money from an ATM, and so on. Reasoning. So is the patient able to cope with unexpected events? So these are the things that we need to check. Spatial ability and orientation. So I think in most movies and cinemas, you always see that dementia patients lost somewhere, trying to get back to home. At the end, they are not oriented. They do not know where they are, even in very familiar places. Language, a lot of times they have problems struggling to find the appropriate words to describe something. Behavior, and of course, there are also other specific symptoms that would point towards a particular cause of dementia. For example, a very acute onset of visual hallucinations that would point towards dementia with Lewy bodies. After we see the patients get the very thorough medical history, we need to evaluate if the patients have dementia or not. However, when it comes to screening, should we screen for all patients aged 65 and older for dementia? The answer is still no, simply because there's no evidence to prove that that screening for dementia is sufficient to determine the balance of its benefits and harms in asymptomatic adults aged 65 and older. That's the reason in the US and Canada, the healthcare professions do not endorse screening or even to recommend screening for dementia in asymptomatic adults. When it comes to history taking, very importantly, as what I highlighted in my previous slides, we need to get the family members or somebody like the spouse who knows the patients very well, so that we can have a very detailed collateral history. And apart from the history focusing on how demented or how likely demented the patients are, medication history is equally important. As you all know, most of the elderly patients, 65 and above, would have been on many medications. And polypharmacy, we need to go through the list to make sure that they are not on those medications that would affect their cognitive function. For example, some sedatives, hypnotics, anticholinergics, and so on. So as you can see from here, we have a list of tools that we could use to assess the cognitive domains of the patient. It can be divided into informant rated, for example, your 88 dementia screening interview, or informant questionnaire on cognitive decline in the elderly, IQ code. And we can also have a series of direct patient assessment, including Mini-Cog, AMTS, MMSE, MOCA, ACE3, BCAT, and SLUMS. And these are all the sensitivity and specificity, as well as whether they are validated in various languages. So I think most of us are more familiar with MMSE and MOCA. And bear in mind, these tests are used to test the cognitive domains, and they are not used to test the moods, the emotions, and the non-cognitive domains. And of course, each test has its own pros and cons, and need to balance among this. So let us talk about MMSE and MOCA briefly, which are commonly used by most clinicians. So I use this table to explain so that it'll be easier for you to understand why in certain cases we do MMSE and why MOCA in certain cases. So both are the same, which are the 30-point scale. And for the MMSE, we assess the patient's orientation, memory, attention, concentration, language, and visual spatial function. MOCA is more or less, but you can see that MOCA does assess the executive function, which is absent from the MMSE. So if you have patients whom you suspect of executive function disorder, in cases such as frontal temporal lobe dementia, MMSE might miss that. So a cutoff point of 23 and less is considered abnormal in MMSE, whereas in MOCA, 26. However, we add one more point for those receiving education less than 12 years. Age, education, and race may appear to have bearings on overall MMSE scores. And MMSE, when you use it, actually you have to require permission, and it's not free. For MOCA, it's freely and widely available. And MOCA has more sensitive values than the MMSE for detecting mild cognitive impairment. When it comes to evaluation, screening for dementia is important. However, we need to equally screen the patients for depression, because depression can be a pseudo-dementia. A lot of times, cognitive impairment may be the sole complaint in a patient with undetected depression, meaning that forgetfulness may not be the complaint of a patient with dementia. People with depression can come with cognitive impairment. Sorry, can come with, for cognitive impairment. So that's very important. Again, it's because we need to treat the patient right. If not, we will miss a diagnosis of depression, and thereby the patient will get worse if the patient is deprived of the supposed treatment. And of course, with somebody with dementia and MCI, undetected depression can also worsen the cognitive impairment when they manage the patients with dementia. So these are the common screening instruments for depression that can be widely available and used in our primary care. That would include the common ones that would include a geriatric depression scale and the patient health questionnaire 9 or PHQ-9. So I'm not going to elaborate more because each assessment takes time to go through. So these are available on the internet. You can have a look later after the talk. After the initial assessment by screening, by medical history, a physical examination is a core aspect when it comes to assessing somebody with dementia. So it's mandatory. The reasons are that we want to find out the cause of dementia as closely as possible. For example, if you find some focal neurological deficits, especially upper motor neuroscience, that would tell you that the patient might have a previous stroke. So that would point towards vascular dementia. And of course, if you have patients with Parkinsonism, the common mnemonic TRAP, which stands for tremor, rigidity, akinesia, postural instability, that would probably tell you that the patient may have Parkinson disease-related dementia. Look at the eyes, look for any ocular paralysis, and especially vertical gaze palsy might suggest progressive supranuclear palsy, KSP. Myoclonic might suggest Creutzfeldt-Jakob disease, CJD. Chorea in young individuals with dementia might suggest Huntington disease. And a near normal or normal physical examination may point towards AD. So this is a very nice graph, cartoon to refresh how a Parkinson patient looks like. And you have a forward tilt or trunk, what we call a stoop posture. And when he walks, he would have a reduced arm swing, shuffling gait, small steps, questioning gaits, rigidity, pure rolling tremors, and head trembling, and so on and so forth. Laboratory testing is crucial, mainly to exclude any potentially treatable or reversible causes. And of course, try to identify the risk factors for dementia as we have discussed earlier. So that would include full blood count, metabolic screening, thyroid function, because we want to make sure that the patient is not having hypothyroidism, B12 and folic levels. VDRL or screening for neurosyphilis is not routinely recommended unless you have a very high index of suspicion that either clinically or from a sexual history that the patient might have neurosyphilis. And when you screened for neurosyphilis, of course, you got to screen for HIV as well, because HIV can cause dementia. What about genetic testing? For AD, it's still very controversial because of the potential for both false positives and false negatives. And we must understand one thing during this genetic testing is that not all patients with who carry the homozygotes for the apolipoprotein E epsilon 4 allele will develop AD. So when we counsel the patient for genetic testing, we need to fully inform pros and cons of getting the genetic testing done. And in addition, as we do not know the specific treatments for the disorders, so testing those patients for this gene, whether this is crucial or not, it remains uncertain. However, if you think that this is genetically predetermined disease, such as Huntington disease, familial prion disease, then it's worth sending their genes to find out the cause of dementia. Structural neuroimaging, such as a CT, MRI, is often used in suspected dementia, mainly to exclude some reversible causes of cognitive decline, such as your subdural hemorrhage, normal pressure hydrocephalus, and some brain cancer tumors. MRI would be subsequently needed if you want to identify the subtype of dementia or when vascular dementia is suspected. So when we look at the MRI, there are a few things that we need to analyze. First is to look at your cerebral atrophy. Cerebral atrophy is, however, common in patients with neurodegenerative disorders, as well as normal aging. We try to look for any lobar predominance, or rather any regional atrophy in all neurodegenerative disorders. So for example, in patients with Alzheimer dementia, the typical atrophic areas would include your mesial-medial temporal lobe, entorhinal cortex, parietal and prefrontal areas. Whereas in behavioral variant of FTD, that would typically affect the anterior temporal and prefrontal. In Huntington disease, the caudate of the nuclei, the caudate nuclei will be affected. For non-fluent variant primary progressive aphasia, it will typically affect the dominant paracerebral. PCA, posterior cortical atrophy, which is considered a visual variant of Alzheimer's disease, will typically affect your parietal occipital areas. Whereas in PSP, you tend to have a midbrain atrophy, or we call it a hummingbird sign. And for semantic variant of PSP, primary progressive aphasia, you get a dominant anterior temporal atrophy. So these are examples that would be typically found in some patients with different types of dementia. So let us look at the left upper corner, patient with Alzheimer's disease. You can see that the medial temporal lobe the medial temporal lobes are atrophied compared with the rest of the regions. And the right upper corner PCA, you can see that atrophy is marked over the bilateral parietal occipital areas. And on the left lower corner, you can see that the midbrain is more atrophied, giving rise to this, what we call a hummingbird sign, which is typically seen in the progressive supranuclear palsy, PSP, and Huntington disease on the right lower corner, whereby you can see a marked atrophy in the basal ganglia, in particular involving the caudate nuclei bilaterally. And of course, MRI is important because we want to look for any ischemic cerebrovascular diseases. For example, in this picture on axial view T2 weighted MRI, you can see a lot of confluent T2 hyperintense signals, subcortical sparing the cortical areas. That would suggest that this patient would have vascular dementia. Whereas on the right, on the gradient echo sequence of the axial card of the MRI, you could see a lot of microhemorrhages, typically in the deep brain structures, which again are indicative of chronic, long-standing, uncontrolled hypertension. That would tell you that this is again most likely a vascular cause of dementia. So we have finished talking about the structural neuroimaging. What about functional? According to the NICE, the use of the PET using beta amyloid and other tracers, SPECT, should only be considered if you think that that would help diagnose the dementia subtype and change the patient's subsequent management. And of course, it's not widely available, so we need to pick the right patient to send for the functional neuroimaging. EEG is important when we think that this dementia or the cause of dementia is a bit unusual, too rapidly progressive, and we think that this is of autoimmune nature. So we need to do that. And EEG in DLB by our colleague Prof. Loh has shown that most DLB cases, we could see some non-specific slowing of background on the EEG. So if you have a patient with normal EEG result, the diagnosis of DLB is very, very unlikely. So what about the CSF biomarkers? On the market, there are a lot, manifold biomarkers for the molecular and degenerative process. So what we are looking at is a low CSF amyloid beta 42 and the increased level of CSF total tau and phospho tau. However, they are still not yet recommended for routine diagnostic purposes. But it is important if you decide to use aducanumab, which is a very new, recently FDA approved amyloid targeted monoclonal antibodies to treat mild AD, aducanumab. We still do not have it in Malaysia. So CSF analysis, again, is important when you want to find out the infectious, inflammatory, and neoplastic processes. Again, for cases such as rapidly progressive dementia, CJD, young patient, HIV, neurosyphilis, or you think that this could be chronic meningitis, a lumbar puncture is indeed indicated. So after doing all the necessary routine testing, now we come out with some criteria how we could firmly establish the diagnosis of dementia. Broadly, we use DSM-5 or the ICD-10. So these are all the domains that we need to check, examine, and I think this is also available on the internet. Basically, we are looking at the 6 domains and to ascertain, whether the patient has any decline in any of these domains. And we have to make sure that we have ruled out the dementia mimics, and those symptoms are not due to depression, schizophrenia, and so on. So I know most of the participants here are from the emergency medicine setting. So I try not to talk too much about how we manage dementia and so on, but I want to highlight the red flags that potentially we might be able to revert or to treat the patients, or even to prognosticate if we think that this disease causing dementia, it's an aggressive one. So these are the three things that we need to remember. If you encounter somebody at the emergency department with a very rapidly progressive course of dementia, younger patients, or you think that the presentation is a bit unusual or atypical, please investigate further and try to find out, or even bring up your friendly physicians or neurologists to find out what's wrong with this patient. So let me just conclude with two cases. Case one is a 50-year-old female, dyslipidemia and type 2 DM, which are very well controlled with medications, reported to have cognitive decline for the past 3 to 4 months, confused. At the end, the family members decided to admit her because of generalized tonic-clonic seizures, and there's no fever. On review, she's disoriented, had a fluctuating GCS scale, no upper motor neuron signs, no signs of meningism, no Parkinsonism. Vitals, including the sugar and the body temperature, seem to be quite normal. And of course, we proceeded with the structural neuroimaging, which turns out to be normal. Blood-wise, apart from a relatively low hyponatremia, sodium level, other blood tests are within normal limits. She has a mildly elevated CSF protein, and the EEG, as highlighted here, shows very scanty alpha activities, predominantly theta activity, slow background in conclusion. So we send some workout, and the thyroid function seems to be normal. However, the patient actually has an elevated anti-thyroid globulin as well as anti-thyroid parasitase levels. So what are we doing? What are we having now at the moment? Any idea from the floor before I tell you the answer? You can just type in the box so you can shout the answer. Okay, let me see. Autoimmune encephalitis, yeah. That's a very good thought. Yeah, somebody with a subacute onset of confusion and so on. Can we tell a little bit more what type of autoimmune encephalitis the patient has based on the results given? Okay, all right. So because of time interest, because of we are running out of time, try to, okay. Hashimoto, wow, that's brilliant. That's right. That's what we call the Hashimoto Encephalopathy, or in a more acceptable term, we call it the SRED, steroid responsive encephalopathy associated with autoimmune thyroiditis. The mechanism of which is largely unknown. Typically, the patient presents with a subacute onset of confusion, automatic seizures and myoclonus, as what was highlighted in our case. So the patient may have a very normal background of thyroid function. The patient might not have a large goiter, glaring at you. We think that this is still an immune-mediated disorder. That's why it's called a steroid responsive. And immediately after the day 3 or day 4 of IV steroid, the patient actually became normal herself. And we discharged her with oral prednisolone, tapering dosing. And after 1 year of follow-up, she remains well and seizure-free and not requiring any anti-seizure medications. So case 2, last case is a 68-year-old male, hypertension, came to CS because of gait instability. He feels weak and has trouble or difficulty initiating his walking. Is easily forgetful, mainly has reduced concentration and attention, and he also reports to have urinary incontinence. Of course, he attributes it to his BPH, benign prostatic hypertrophy. So on examination, there's mild rigidity of both upper limbs, and his MOCA is 24. So if any one of you has really got a clue of what we are dealing with, you just type in the chat box or even you can shout out. Okay, this is the video of how he walks. I hope it plays well. So this is our lovely medical ward of UKM Medical Center. You can see that when he turns, he struggles, shuffles. Yeah. Okay, he's being very careful in walking because he doesn't want to trip and fall. Okay, so someone says Parkinson's. Yes, he looks a bit, yeah, because of the rigidity, because of the fastening gaits, because of the turn on block. Yeah. So any other, okay. Normal pressure hydrocephalus. Okay, all right, let us see what happened next. Okay, I think after this, you probably are more confident about the diagnosis. So you can see from here, the axial part of the scan reduced grossly enlarged ventricles. Yeah. And the Avon index is more than 0.39. Yeah. This is one of the ways to ascertain, or to confirm whether this patient has normal pressure hydrocephalus versus versus hydrocephalus due to aging. So what we do, we measure the maximum width of the frontal horns of the lateral ventricles and the maximal internal diameter of the skull at the same level. So normal ratio should be less than 0.3. And this patient has 0.39. However, this Evans index is not that specific. So we can have other features to suggest whether this is MPH. There's something we call callosal angle. So we measure the callosal angle, which is on the coronal image cut perpendicular to the anterior commissure to your posterior commissure. So at this plane, we measure the angle, yeah, which is called the callosal angle. So in normal person, it should be around 90 to 100. As you can see from this patient, it's about 54, close to 55, which is very acute. So an acute callosal angle is also suggestive of MPH. So normal pressure hydrocephalus, is actually referring to a condition of pathologically enlarged ventricular size or ventricular megaly. So this is not due to the aging or age-related atrophy. And MPH is a form of communicating hydrocephalus. So it should not be non-communicating. So if when you have something, ventriculomegaly due to non-communicating, you always have to find out the cause because it's more emergency. Then you might need to have an emergency shunting. So the classic triad would include dementia, gait disturbance, or we sometimes call it as gait apraxia. The patient has even difficulty in starting walking and urinary incontinence. So potentially, once we diagnose it, some of the symptoms or signs can be reverted or reversed by the VP shunt. That's why it's very important and crucial to recognize it. So this is what we call the time up and go test. So what we do is that we think this is MPH. So we do a lumbar puncture, we draw a large volume of CSF, and now we see how he walks. He actually walks faster. Of course, there's still some hesitancy, and the strides are wider and is more confident. So this is a positive time up and go test. So what I do is I ask the patient to stand up, walk forward 3 meters, and turn back. So VP shunt was inserted and it was stable in his gait. So we are almost coming to the end. If you suspect or encounter any patient with dementia, you are not alone. Why? Because I think dementia is probably one of the diseases whereby many people can actually treat and manage the patients. For example, psychiatrists, geriatric psychiatrists, neuropsychiatrists, neurologists, geriatricians, physicians, and any family medicine specialists are trained in taking care of geriatric care can actually manage and initiate treatment for PWD. So there's actually no reason for you not to refer or not to manage the patients with dementia. And again, we have this Alzheimer Disease Foundation Malaysia, NGO patient support group that would actually tell healthcare providers and patients and family members what to do and what the expectations are, for the patients as well as the caregivers. And again, we have the 3rd edition of Management Dementia. So it can be accessed at this website. You can Google and you can download. It's freely available and downloadable. So you can read more from this. I think this is a very nice CPG guideline, which has all the tests and the flow chart on what you should do when you have a patient with dementia. So as I conclude, the prevalence of dementia has dramatically increased. Prevention is always better than cure. As you know, once you diagnose somebody with AD, vascular dementia, there's literally no cure. So what medications that we have are actually to help alleviate the symptoms. Sleep more, very important for all of us, and optimization of the risk factors. Sorry, there's a spelling mistake. Is crucial to prevent the development of dementia. And ladies and gentlemen, it's very important to recognize dementia mimickers and also the red flags to avoid any potentially reversible treatment causes. And I apologize for any limitation of my talk as I did not cover specific types of dementia in details and also the management of dementia due to the time constraint. With that, I would like to say thank you, and I'm happy to answer the questions. Back to you, Nas.
Okay, so thank you very much. I think it was a very insightful talk from Dr. Khoo. And I think myself, I thought dementia is all about having memory loss, but I gained a different perspective that especially in autoimmune encephalitis, they can come with neuropsychiatric behavioral changes. They can become psychotic, inappropriate behavior until they come in with seizure. And if we do not detect them at a particular point of time or start the treatment early, they can basically succumb to death. So thank you so much. I think this is a very nice general overview. And I really like the summary of if you have certain symptoms like Huntington disease, you will have chorea, for example. That is pretty helpful. So I would like to open further questions from the participants. If you have any, you can unmute yourself and ask to the presenter directly. Or if you're a bit shy, you can type it inside the chat box and I will read out for you. So while waiting for that, I have one question actually to Dr. Khoo. Can you please clarify, because you mentioned that if the patient is taking analgesia for whatever purpose, it can also increase the risk of patient getting into dementia. So what type of analgesia we're talking about? Is it opioid based or NSAID based for that matter?
Well, thank you for the question. I'm sorry I didn't get time to elaborate more. So yeah, you're right. Opioid analgesics, we need to be very careful because, opioids, I'm sure emergency healthcare professionals do prescribe a lot. So tramadol, all this opioid base, we need to be very careful, especially when they take it or abuse it. Sometimes they just take, this opioid-based medications very regularly. It can actually cause them to uh, have problems, in terms of their cognitive function and so on. So, in a nutshell, any medication that could act on the central nervous system, we have just got to be very careful. Yeah, I know they're very comfortable, but abuse of any of these drugs, when it comes to elderly, we have all the pain. Actually, it's not just elderly. I think all of us,
Yes.
some of us might have some pains and aches somewhere. Then what we do is that we don't seek treatment and try to buy some over-the-counter medication. So yes, opioid, NSAIDs, the same. We need to be very careful because NSAIDs could give rise to a lot of issues in the elderly, like renal impairment, UGIB. So when you have an MCI, for example, any event or bodily stress can actually make the symptoms worse. So, for example, you have this level of your cognitive dysfunction as a baseline because of one event, for example, an UGIB, your cognitive function will just drop like that. And it would take very, very long time for you to recover. However, you may not go back to your baseline anymore. So this is what we are dealing with. So I think our next speaker, who is a geriatrician, I think will talk more and will be very, very unhappy, if the physicians prescribe too many medication to address each and single disorder, the so-called polypharmacy. We need to justify, we need to be very careful. Otherwise, we cause a fall, for example, that would cause the patient to be unable to go back to the baseline. So yeah.
All right. Sure. Thank you so much. I think, from the emergency department, we love to prescribe patient with tramadol. I think I have this kind of like anti-tramadol kind of feelings inside me. Opioid based, because it can, yes, it's good for the patient temporarily, but it's not for lifetime prescription, I guess. So we have one question from Leon. Thank you for excellent lecture. May I ask, is vitamin D deficiency a cause of dementia? What do you think about that?
Oh, a good question. Thank you. I don't have an answer. I don't think so. We have any strong evidence to say that vitamin D deficiency is strongly related to dementia. I have no idea, but I don't think so at the moment. We have any strong evidence to suggest that. Yeah.
All right. So do we have any more questions? I think another interesting factor is because Alzheimer disease, they overlap with many other psychiatric presentation. They're talking about neurofilament detection or something. I think that's pretty awesome if we can have it, but I don't think so it's yet in Malaysia. Have you heard about it?
Sorry, again, Nas, what you saying? Yeah.
No, the neurofilament blood testing or something. It can, if apparently if you have like some kind of your neural system is being destroyed, you will find it inside your CSF and also in your bloodstream.
Okay. Yeah, that's for some cerebral injuries, but I don't think it's needed. Yeah, it's one of the tests that we can assess the neuronal injuries. Yeah, but I don't think it's used for patients with dementia. Yeah.
All right. Okay, I think the question which was posed by Leon earlier being answered by
yeah. Thank you so much.
All right, thank you, Prof.
For answering that. Yeah.
All right. So do we have any more questions? I'm gonna count it 5, 4, 3, 2, 1. So if there is none, I would like to thank Dr. Khoo again for your excellent talk today. And I believe that the participant has gained quite a number of knowledge from it. we hope that we'll be able to invite you again in the future, perhaps.
Thank you so much. The pleasure is mine.
All
Have a
right.
nice day.
Okay, thank you. All right, I'm just going to end the recording.